Good morning, everyone. Welcome to Academy, where you can crack all NEET PG exams with us, with our quality content, top educators, and have a great experience. So, a little about me. I'm Dr. Sasha Remedies. I've done my MBBS from Father Muller Medical Anesthesia from Father Muller College. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. Today we will complete this topic on non-operating room anesthesia. I dealt with it in one part yesterday. Today I shall complete the second part of this topic. So a little about Unacademy now, one of India's largest online learning platform where you can get plus subscription and access to live and courses, all from India's best educators. Now, what will you get out of Unacademy? So, at Unacademy, we have our daily life classes. So, when you go to a coaching institute, you can't really, how do I put it? When you go to a coaching institute, it's not really practical for yeah. So, when you go to a coaching institute, it's not very practical. So you have to get up, get ready. There's a lot of time waste, energy, and again, once you get there, you have to make sure that you have a good place, and your educator can, your educator should be here. Everyone, hodgepodge have. Whereas at Unacademy, you can chat with your educator, engage in discussion, ask your doubts, and all by them. These are structured courses, so all our courses are structured and in line with your exam syllabus to help you best prepare for it. So the educators have researched and whatever is important for you all from me point of view, based on that only classes are prepared. Then there are regular live tests and quizzes. So the educators conduct regular tests and quizzes which will help you all to evaluate your performance on a regular basis. Then unlimited access. So one subscription can get you access to all our live and courses, and you can watch from the comfort of any of your devices in your home. So wherever you are, whatever you are doing, you can watch from the comfort of your device. These are some of our top educators: Dr. Nikita Nanwani, Dr. Mohammed Zam, Dr. Divesh Mishra, Dr. Sharma. Dr. Nikita Nanwani is a NEET PG mentor for radiology as well as mnemonics and concept focusing on many must-know topics which encompass almost all subjects. Mnemonics is a very interesting, I would say, a very interesting point of view. For those of you who mnemonics helps, I would say go for it, and it would be really helpful. For me personally, it never worked. But for those of you who works, I would suggest even make your own mnemonics, as you all can. Now, batch courses, and now as you can see, there are so many subjects that you cover, like almost like 19 subjects that you all have to cover, and under each subject there is quite a lot of for you all to cover. Now, what I would say is uh, there are different courses under each subject. It's not easy, and all your MBBS subjects you have to cover at once, but it can't be helped, right? You have to do it, and we are here to help you do it. However, to the best of our ability. So, however we can help you, we will help you do it. Also, like I said, um, topics like psychiatry, radiology, anesthesia, dermatology, all these subjects. Well, all these subjects are allotted 11 marks each, and like you all never really went into detail during your topic. Here too, you don't have to go into that much detail into these topics. These topics are not, they are not being covered in so much of detail, but you cannot answer those 11. Those 11 marks are easy marks, I can tell you much, but you will not be able to get those 11 marks unless you go through the material and in these subjects, under these subjects, listen to some classes, go through material, give some quizzes, revise. So once or twice if you'll do that, you should be able to answer questions in these subjects. However, the subjects like physiology and allotted 44 marks each. You'll have done these for 1 year each during MBBS. They can ask you anything from anywhere when it comes to these subjects. Then these are some of the ongoing courses on our platform. That is course on neurophysiology, GI surgery, cardiovascular thoracic surgery, capsule on the larynx, pathology, respiratory system. So coming to the subscription now, there are 5 types of subscription on the screen. As you can see, for those of you who are giving NEET PG this year, 6-month subscription should suffice. For the rest of you, I would recommend the 12 and 24-month subscription. Now 12 and 24-month subscriptions are more economical because you have that buffer time to sit and complete, like after 6 months, once if you don't clear NEET PG, or if you don't like the subject you want to give NEET PG again, and you want to access some live and or recorded courses or do some test papers, it won't be possible for you all, right? It will be very hard for you all. So you will have to pay again. Whereas with your 12 and 24 months, of course, you have that buffer time. Then also, then also 12, 24 months, and then further on, there's no harm in taking on. So this time actually can help you all think about what you all want, what you all might enjoy studying. So because you all are studying so many subjects, you all will realize maybe what you really want, you will realize you don't enjoy studying it. It might not be practical, but studying from the theory point of view too, these subjects are important because you have to do that for the rest of your life. So here your priorities might change in this 1 year, which might be a good thing too, because you'll have to do these for the rest of your life. You'll need to enjoy what you do, right? So like you can see at the bottom of the screen, my code SASHA, you can avail a 10% discount. So the 12 months code, as you can see here, avail a 10% discount. Then also on the 24 months, you can avail a 10% discount. No harm in dropping 2 years. Nobody will ask you how long you took your NEET, why you took so long. Now this is non-operating room anesthesia as well as ambulatory anesthesia. So now coming to the topics. So we'll continue. I'll just briefly run through yesterday's class. It's an easy topic. So American Society of Anesthesiologists, it endorses and supports the concept of ambulatory anesthesia and surgery. ASA encourage anesthesiologists to play a leadership role. So this covers ambulatory anesthesia as well as non-operating room anesthesia. So the ASA encourages anesthesiologists to play a lead role as the perioperative physician in all hospitals, ambulatory surgical facilities and office-based settings. And the anesthesiologist should participate in accreditation and as means of standardization of protocol. Now the ASA guidelines are briefly: the guidelines and policies should be adhered to in all settings except when they are not acceptable to the outpatient care. Just a sec, guys. Yeah. So a licensed physician should be in attendance in the facility or the overnight, in the case of overnight care, immediately available by telephone at all times. So there should always be someone for post-operative care once the patient is, if the patient is kept post-operatively. Ambulatory, usually they get discharged. They should not be kept overnight. That is the point of an ambulatory surgery, but sometimes they have to be kept. And then the facility must be established, constructed, equipped, and operated in accordance with applicable local, state, and federal laws and regulations. So it must be established, constructed, equipped, operated with all the basic needs should be there. A minimum source of oxygen, suction, resuscitation equipment, and emergency drugs have to be available. Staff should be adequate to meet patient facility and needs for all procedures performed in the setting, and it should consist of a professional staff like physicians and other practitioners who hold a valid license or certificate, nurses who are qualified, administrative staff, housekeeping, maintenance. Then physicians should assume the responsibility for credentials review, that is reviewing the quality, etc. Qualified personnel and equipment should be on hand to manage all emergencies. There should be minimal patient care, which should include perioperative instructions and preparation. So a pre-operative, not pre-operative instructions and preparations. So pre-operatively, the patient should be reviewed, evaluated, and the comorbidities assessed. Basic review done of the patient, and what is best from the patient. What is best for the patient seen to, because that is what is important. So in the event that the non-physician personnel are utilized in the process, and even so basically or in any investigations that would be required from the point of view, see if the patient is diabetic, then you might need to repeat the morning sugars, fasting sugars, electrolytes, and UKB just to know, or glyco-HB just to know the sugar status of the patient, because you have to keep the patient fasting, so you have to see how the patient is doing. So that's why then in a hypertensive, you'll have to tell the patient to take the blood pressure medications on the morning of the surgery, also continue the medications. Then thyroid patients, you'll have to check the T4, T3, T4, TSH levels. So based on that, auscultation of the chest to see if there are any, if the patient is medically fit, if there are any wrong palpitations, if the patient is asthmatic. You have to know about the medications. You have to see whether you need to pre-operatively, give the patient a nebulization. So all these things should be evaluated prior. There is no emergency for these surgeries. Sometimes yes, non-operating room, and earlier it used to be all well planned and easy, but now not even so. Earlier only ASA 1 and 2 patients used to be taken, but now even 3 and 4 patients are being taken. So preferably a good pre-operative follow-up should be done, and an appropriate pre-anesthetic evaluation, examination by anesthesiologist prior to surgery, etc. should be done. Oh, sorry. Then minimal pre-operative studies and consultations as medically needed. An anesthesia plan is developed by an anesthesiologist, discussed with and accepted by the patient and doctor. Okay? Administration of anesthesia by anesthesiologists, other qualified physicians, non-physicians, anesthesia personnel, medically directed by an anesthesiologist. Then minimal patient care should include uh, discharge of the patient is a physician's responsibility. Patients who receive other than non-supplemental local anesthesia must be discharged with a fully responsible adult. Written post-operative and follow-up care instructions, accurate, confidential and current medical records should all be maintained. So there should be someone to be when so ambulatory anesthesia not always will be a regional anesthesia, right? So if the patient is undergoing any anesthesia, it should be seen to that there is a responsible adult that can be discharged with the patient, right? And basically written post-operative follow-up care instructions all should be maintained so that the patient can follow these instructions appropriately, right? And prior to the procedure, it has to be explained to the patient too about the procedure, etc. Consent has to be taken. That is very, very important. And now coming to non-operating room anesthesia, it is a general guide to the cadence and focus of procedures performed outside of the OR and highlight some of the adaptations, both cultural and practical. The main purpose is to highlight the intrinsic, common, and unique characteristics of non-operating room anesthesia cases. So basically to highlight so we'll be discussing the unique characteristics of these cases that impose problems on an anesthesiologist, and the second is to present goals, methodologies and pitfalls of interventions that may be unfamiliar for anesthesiologists. So basically with this non-operating room anesthesia, I'll just give you all a brief overview and we can move. So there are a lot of operational constraints. So there are a lot of financial as well as operational constraints with this non-operating room anesthesia. So the locations are often adapted, to specific to the procedure being undertaken and needs of the medical practitioner. So the location is altered to that. Then variability may be more problematic because the number of staff in one OR room is very small and less flexible. They are more for the medical practitioner, so that can be a problem. Then block time may not be in place, and anesthesia cases can be placed anywhere on the schedule, right? So the anesthesia cases can be placed anywhere on the OR schedule, and the lack of storage place for anesthesia equipment may impose longer turnover time and the need for additional anesthesia and technical services. So overall it can become a huge problem. Good morning, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET together. A little about me. I am Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore, and I have been working and teaching in Bangalore for the past 2.5 years. Sorry, I think with the previous think there was some problem. I don't know what happened, so I'll just run through the class again now. Uh, okay, I think it should be okay, so I will continue with the class. So the statement on anesthesia care for endoscopic procedures. So basically, the statement on anesthesia care for endoscopic procedures. So basically, the so it is a position of, yeah. So like I was telling you all, I thought there was some problem, but I think we can continue with the class. So that's what I'll be doing now. Like I was saying, so the complications with this non-operating room anesthesia are basically the locations. Like I said, the locations are more adapted to the specific procedure being undertaken and the needs of the medical procurement proceduralist. Then there may be, the variability may be more problematic because the number of staff in one OR room is very small. They are not interchangeable, they are not flexible, and the block time may not be in place. So the patient may be scheduled now, then the next patient may be scheduled, excuse me, may be scheduled after 4 more procedures. So it is very variable, right? It is not fixed. So it becomes difficult for the anesthesiologist to schedule. Then non-OR procedures may take, non-operating room procedures may take place far away from the OR. There can be lack of storage place for anesthesia equipment, and many such problems can be there. Um, so many non-OR procedures suites perform procedures on patients referred from outside providers of services, etc. So it is difficult to estimate the length of time of these procedures too, because they are novel procedures. They can sometimes just get over really quickly, sometimes they can just take very long. So it all depends on each patient, each doctor. So it's very difficult to estimate the amount of time that these procedures will take. So um, how can all this be overcome? Maybe, real-time scheduling. A schedule can be created by talking to the medical practitioner and scheduling it in such a way, telling them that you all also need some priority, as you all have other OR cases going on. Then basically a good contract between anesthesiologist and the medical practitioner should be established, and procedural triage should be made as to the ones that are most important to be put first, and also to the anesthesia ones being put first or being put last, however the schedule is easy. So like for example, we'll just deal with anesthesia care for endoscopic procedures. So it is a position of the American Society of Anesthesiologists that there is no circumstance when it is considered acceptable for a person to experience emotional or psychological duress or untreated pain amenable to safe intervention while under a physician care. So anesthesiology is a discipline within the practice of medicine that involves safeguarding and medical management of patients. So therapeutic endoscopic procedures are ones which usually require anesthesia. Then particularly comorbidities, mental health, psychological impediments to coordination are examples of conditions dictating anesthesia care for minor procedures. So basically for major procedures, definitely anesthesia care would be required. But from minor procedure point of view, any patient having mental or psychological problems, comorbidity, etc., it's always good to have anesthetist as standby. Um, then procedures that are painful may need anesthesia. Then certain procedures where the procedurist, the medical practitioner himself was not able to perform, so under sedation the patient was not cooperative, then of course uh, an anesthesiologist would be required. Then procedures that come under this are biopsies, polyp resections, endoscopic ERCPs, biliary tract procedures, dilatation of intestinal structures, etc. So basically, risk benefit requirements, procedure requirements, patient factors and preferences, competencies of involved practitioners, all should be kept in mind always. Then now coming to ambulatory anesthesia. Now coming to the general information on ambulatory anesthesia. Some key points are: the procedures appropriate for ambulatory surgery are those that are associated with post-operative care, that is managed at home, and with low rates of post-operative complications that require intensive physician or nursing management. Just a sec, guys. Just a sec, hold on. Yeah, sorry. So, the procedures appropriate for ambulatory surgery are basically those procedures where post-operative care can easily be managed at home with low rates of post-op complications. Then whatever the age, ambulatory surgery is no longer, like I said, restricted to ASA 1 and 2 patients. 3 and 4 is also taken. For patients with OSA, it is always preferable to go in for local or regional anesthesia because these patients present with a lot of complications in themselves. So it is always preferable to go for local or regional anesthesia with these cases. Then for adults, airflow obstruction has been shown to persist for up to 6 weeks after viral uh, respiratory infection. So it is advisable that surgery should be delayed if an adult presents with a URI for 6 weeks, after 6 until 6 weeks. Then in 1999, the ESA published practice guidelines for preoperative fasting. The guidelines allow a patient to have a light meal up to 6 hours before the procedure and support a fasting period of clear liquid. So basically, the fasting guidelines where no liquid for 2 hours and solids for about 6 hours, right? Rest milk 4 hours. Then the post-operative pain control is actually best with regional techniques. Compared to general anesthesia with regional techniques, time until discharge. Actually, between general anesthesia and regional anesthesia, it was noted that time to discharge was no different for the three groups. The time to discharge was no different. Post-operative pain control is best with regional techniques, and nerve block using catheters can be placed before surgery that can be used to provide analgesia after sedation. So after induction doses of propofol or thiopentone, so thiopentone can appear to cause impairment for up to 5 hours, but with propofol only 1 hour. So basically, the risk benefit of the drugs should be weighed, and based on that, the drug should be used. Then, so basically, we need to be concerned about the speed of wake up and the incidence of post-operative nausea Vomiting. So now this post-operative nausea vomiting too has to be kept in mind, as it has to be prevented in these patients to the best of our abilities, right? We should not uh, this ambulatory, because these are quick surgeries, so the risk of post-operative nausea vomiting is little higher. Excuse me. Then it is important to distinguish between wake up time and discharge time. Wake up time is basically when the patients emerge from anesthesia and abilities to sit, stand, and tolerate fluids, etc. And discharge time is when the patient. So here the patient may though he may be able to sit, stand, and tolerate fluids, and the time to fitness to discharge may be no different, but sometimes there can be some difference. The patient might still be drowsy and might require some time to discharge. So nausea is an important and most important contributing factor. So the contributing factors for the risk factors for nausea are the female sex, non-smoker, history of previous PONV, post-operative use of opioids, and the maximum possible score is actually 4. So use of post-operative no opioids, history of PNV, female, and non-smoker, right? So 0 points is indicates generally a risk of PONV is only 10%, and 4 points indicates that the risk of PONV is around 80%. Okay, so many ambulatory surgeries. So the patient, many ambulatory centers have a room known as a phase 2 room, where the patient may stay until they are able to tolerate little fluids, walk, and void urine. Now, this is what we are going to be dealing with today. So the place, procedures, and patient selection, upper respiratory tract infection, restriction of food and liquids before. So basically, um, you have to discuss the place, the procedure, and the patient selection. Do a pre-anesthetic checkup. Check for any upper respiratory tract infections. Delay if needed for 6 weeks. Restriction of food and liquids, that is of NPO guidelines. Pre-medication to reduce anxiety, and these people will be fasting, so it's good to give even what you call it antiemetic, etc. Benzodiazepines, opioids, non-steroidal analgesics, etc. to decrease pain. Intraoperative management, choice of anesthetic methods or regional techniques, spinal caudal, nerve block, sedation and analgesia, general anesthesia, paralysis. So intraoperative management of postoperative pain, depth of anesthesia, and airways. So management of post-anesthesia care, reversal of drug effects, nausea, vomiting, pain, and preparation for discharge for patient. So now the place, procedure, and patient selection. So ambulatory surgery occurs in a variety of settings. Some centers are within a hospital or in a freestanding satellite facility. The independent facilities are often for profit and not located in rural or inner city areas. Then physician offices may also serve for procedures. Freestanding independent facilities will continue to grow in number and popularity. Now, the problem with these freestanding ambulatory facilities, which are not attached to a hospital, they may force some hospitals out of business, but plus these may not be adequately staffed, and hospitals are usually a non-profit and care for patients who both can and cannot pay. So some surgeons may work exclusively in a freestanding facility and may not be on the staff of a hospital. So the requirement for hospital staff privileges frequently is that a physician provides coverage for the hospital emergency department. Some hospitals have lost emergency department cooperation too, coverage too. So now procedures appropriate for ambulatory surgery are those that are associated with post-operative care that can be easily managed at home and with low rate of post-operative complications. So based on that, patients are selected for ambulatory surgery. So establishing a low rate of post-operative complication depends on the relative aggressiveness of the facility the surgeon, patient, and payer. Now coming to the place procedure and the patient selection. At the other extreme of life, advanced age alone is not a reason to disallow surgery in an ambulatory setting. Age does affect the pharmacokinetics of drugs. Even short-acting drugs such as midazolam and propofol have decreased clearance in older individuals. Increased age may be a factor of likelihood of unanticipated admission. So age plays an important role as extremes of life. Obviously, there are various physiological changes, so a lot of things can occur. So most medical problems that older individuals may experience after ambulatory procedures are not related to patient age but to specific organ dysfunction that comes along with age. They will have different dysfunction, so there is a high chance of uh, post-operative the patient unanticipated admission. Hence a careful pre-operative history and physical examination should be done. Like we discussed, ambulatory surgery is no longer restricted to only one ASA 1 and 2 class patients. Even ASA 3 and 4 are appropriate candidates for providing this. Then we have for patients with OSA, if so for patients with OSA, if a procedure is performed as an outpatient procedure and local or regional anesthesia is used, the procedure can also be performed as an ambulatory procedure, right? Yet for patients who are at increased risk for post-operative complications, the procedure should be performed in a freestanding ambulatory surgery facility. So now patients who undergo ambulatory surgery should have someone to stay with them afterwards and take them home, right? Stay with them and take them home. So before the procedure, the patient should receive information about the procedure. There will be certain laboratory tests that will be ordered, NPO, whatever the NPO guidelines will be will come into interplay. The patient must understand that he is going to go home on the day of the surgery, after the surgery. Then once at home, the patient must be able to tolerate pain and assume adequate pain therapy. Okay, and the post-operative instruction should be there as to and how to the pain coverage also should be given. Most patients are satisfied with an early discharge. Very few prefer to stay in the hospital. Certain procedures like for lap chole and QRP, transurethral resection of prostate, should live a little closer to the ambulatory facility because post-operative complications may need them to get back. Then upper respiratory tract infection. So, upper respiratory tract infection, airflow has been shown to persist for adults. Airflow, it has been shown to persist for up to 6 weeks after viral respiratory infections. Hence, surgery should be delayed if an adult presents with the upper respiratory tract infection until 6 weeks have elapsed. In case of children, the surgery should be delayed. Length of time is questionable, ideally till the URTI subsides. Now, children with active or recent URIs have more episodes of breath holding, incidences of desaturation, and more respiratory events compared with children without symptoms. Right? So, if a patient with a URI has a normal appetite, does not have fever and elevated respiratory rate, and does not have, it might be safe to proceed with the procedure. So, it is all a risk and benefit ratio. Now, restriction of food and liquids. Coffee and tea drinkers should follow fasting guidelines but should be encouraged to drink coffee prior to the procedure because physical signs of withdrawal can occur. There is some evidence that shorter periods of fasting are accompanied by less post-operative nausea vomiting. So 2 hours for clear liquids like water. 6 hours for liquids. These are the universal guidelines. 6 hours solids, 2 hours for clear liquids like only water and apple. Any other pulpy liquid like grape juice or musambi juice and all, it is 6 hours only. So now patient anxiety. So pre-operative reassurance and providing a booklet. So talking to the patient, telling the patient about the procedure itself can reduce pre-operative anxiety. For a child, most of the anxiety is because of separation from parents. Then family-centered therapy consisted of providing the families of children with, videotape, pamphlets, mask kit practice. So basically, just little small practices before the procedure so that the child becomes a little more open. Then anesthesia pre-medication. So benzodiazepines pre-medication is useful to control anxiety, post-operative pain, nausea, vomiting, and to reduce the risk of aspiration during the induction of anesthesia. Then benzodiazepines are currently the drugs most commonly used. Midazolam is a benzodiazepine most commonly used preoperatively, and it can be used intravenously and orally too. Sorry. So for children, oral midazolam in doses as small as 0.25 mg per kg produces effective sedation and reduces anxiety. With this dose, most children can be effectively separated from parents after 10 minutes and satisfactory sedation can be maintained for 45 minutes. So in adults, particularly when midazolam is combined with fentanyl, patients can remain sleepy for up to 8 hours. Although children may be sleepy after oral midazolam, discharge times are not effective. So, so children may remain sleepy after this midazolam, but discharge time will not be affected as they can maintain their airway. Now, at proper doses, neither midazolam nor diazepam place patients at any additional risk of cardiovascular or respiratory depression. Oh, I'm sorry. So both these drugs are cardiostable. The potential for amnesia after pre-medication is another concern, especially for patients undergoing ambulatory surgery. Anterograde amnesia easily occurs, so it's preferable that these patients have someone with them when they go home. Oral diazepam 2 to 5 mg per kg body weight is prescribed the night before the surgery at around 6 a.m. on the day of the surgery, even if the surgery is scheduled for 1 p.m. or later. Midazolam 0.01 milligram per kg is administered IV. Propofol 0.7 milligram per kg for children, 0.25 midazolam per kg, and when the child is asleep, as paracetamol can be put rectally, and diclo also can be given put rectally or given intravenously for prior to initiation. So pre-operative administration of opioids or non-steroidal anti-inflammatory drugs may be useful for controlling pain in the early post-operative period. And if rectal acetaminophen is used in children, an initial loading dose of 40 mg per kg is appropriate. Subsequent doses of 20 mg per kg every 6 hours can be used, right? So when preoperative rectal acetaminophen is combined with ketoprofen for painful procedures, post-operative pain is less when the drugs are given individually, right? So it's basically multimodal analgesia. So rectal paracetamol combined with the diclofenac, that is ketoprofen, similar to the diclofenac. So when post-operative pain will be less when the drugs are given individually, like they are given individually, but it is like a multimodal analgesia. So intraoperative management, regional techniques. Performing a block takes longer than inducing general anesthesia. Failure also can be high. Unnecessary delays can be obviated by performing the block beforehand. Then post-operative nursing intervention, usually associated with general anesthesia, is for about 45, can be associated with a 45-minute delay. The increased setup time for regional anesthetic may be associated with a shorter time to discharge. And post-operative pain control, of course, this is a very important point, is much best with the regional technique. So children, spinal anesthesia is used in some centers, usually used. Adult lignocaine and mepivacaine are ideal because they are short, duration of action is short. So the short duration of action, and lignocaine has been problematic because it has been known to cause transient neurological symptoms. Both ropivacaine and bupivacaine have been used, but recovery time is pretty long. Spinal should be avoided in ambulatory patients because they may be more active post-operatively than in patients. Bed rest does not reduce the frequency of headache, and indeed early ambulation may decrease the incidence of post-operative post-dural puncture headaches. So epidural is quite time consuming. It takes longer than spinal anesthesia, and the onset is with spinal anesthesia is more rapid than with the epidural. Caudal is a form of epidural. It is performed generally in children. It is more to control post-operative pain. It is not generally used as a primary method for anesthesia in children. So the block is usually administered when the child is anesthetized. It is for better pain control. They can ambulate earlier and can be discharged sooner with a caudal block because of better pain control. Now, pain control and discharge times are no different whether the caudal block is placed before the surgery or after the surgery is completed. Now, coming to nerve blocks, they were shown to be widespread use of axillary and interscalene blocks for surgery in the upper extremity, and of ankle and femoral blocks for the lower extremity surgeries. Then, nerve blocks improve post-operative patient satisfaction. PONV and post-operative pain are less, and costs are also less. Patients who go home with catheters inserted must be taught about the infusion pump function and understand signs of local anesthesia toxicity. Also, the patient must be able to communicate to someone by phone. The number of patients who have been sent home with catheters is increasing but is not very large. Now, sedation and analgesia. Many patients who undergo surgery with local or regional anesthesia prefer to be sedated and to have no recollection of the procedure. So, the patients who are sedated and under sedation and analgesia, they undergo surgery with and I have no recollection of the procedure. Sedation is important in part because injection with local anesthetic can be painful, and lying on a hard OR table can be very uncomfortable. Then levels of sedation may vary from light during which a patient's consciousness is minimally depressed to very deep in which the protective reflexes are partially blocked and response to physical stimulation of verbal command may not be appropriate. So sedation may vary. Now, general anesthesia, the popularity of propofol as an induction agent. The elimination half-life is around 1 to 3 hours, and it is shorter than for methylxetal or thiopental. So after induction, doses of propofol or thiopental they causes psychomotor impairment for almost 5 hours as compared with propofol, which causes only for 1 hour. So pain on injection also can be a problem with propofol, and thrombophlebitis is not that much of a problem. Um, so most children will not have intravenous catheters, IV lines inserted before the start of anesthesia. For short procedures, some may not, and they generally do not require neuromuscular blocking. Others, for a brief paralysis, succinyl choline can be given. Now, for maintenance, two primary concerns are speed of wake up and incidence of PONV. These are the two major concerns. So, propofol has a short half-life and can be used. Desflurane, sevoflurane have low blood gas partition coefficients, um, and these three seem to be ideal for general anesthesia for ambulatory surgery. Sevoflurane, like desflurane, facilitates a smooth inhalation induction and the preferred technique to ensure rapid recovery of children in ambulatory centers. The importance to distinguish between wake-up time and discharge time. So patients emerge from anesthesia with DES and nitrous oxide significantly faster than after propofol or sevoflurane, right? Now, post-operative nausea. So, nausea with or without vomiting is important contributing factor to delay in discharge and increase in unanticipated admissions. So, women, especially those who are pregnant, previous history of motion sickness or post-anesthetic emesis, surgery within 1 to 7 days of a menstrual cycle, not smoking, laparoscopy, lithotripsy, breast surgery, ear, nose or throat surgery have an higher incidence of PONV. Then basically the treatment is selective serotonin antagonists like ondansetron, granisetron, dopamine antagonists, antihistamines, anticholinergic drugs are useful, neurokinin receptors therapy. So basically a multimodal approach to PONV. So avoidance, so basically how can this PONV be prevented? So avoid nitrous oxide, try to reduce on the inhalation agents as both cause PONV, avoidance of muscle relaxant reversal if clinically indicated, avoidance of narcotics, adequate fluid hydration, administering of 5-HT3 serotonin antagonists, an antiemetic of a different class, dexamethasone, so it can be helpful. Muscle paralysis is generally not required, and if required, like I said, maybe short acting like succinyl choline can be used. Now, post-operatively, intraoperative management of post-anesthesia care unit. So basically, delay for discharge can be due to drowsiness, PONV, nausea, vomiting, and pain. So all three are a function of intraoperative management, but nausea, vomiting, pain can also be treated in the post-anesthesia care unit. So reversal of opioids may sometimes be necessary. Flumazenil, benzodiazepine receptor antagonist, can be used. It should not be used routinely as benzodiazepine antagonist, but may be used when sedation is too much. Nausea and vomiting are also common adverse effects. So in adults, granisetron 40 microgram per kg, metoclopramide 2 or hydroxyzine 25 mg are successful. Dexamethasone, also given antiemetics, can enhance the treatment of established PONV. Midazolam and propofol also have antiemetic effects that are longer in duration than their effect on sedation. Pain, post-surgical pain may be treated quickly and effectively. It is important for the practitioner to differentiate between post-surgical pain from hypercapnia, full bladder, and discomfort of hypoxemia. When swelling and pain are problematic post-operatively, NSAIDs can be more effective than opioids in relieving both. So preparation for discharge of the patient. The patient should be informed that they may experience headache, pain, nausea, vomiting, dizziness, and a patient will be less stressed if the described symptoms are expected in the course of normal recovery. Written instructions are important. The addition of written and oral education techniques at discharge has a significant, so written instructions are very, very important, right? So this is the modified Aldrich scoring, which is a highly acceptable criteria for discharge of patients from the post anesthesia care unit. So propose the fast track criteria to determine whether the outpatient can be transferred directly from the operating room to phase 2 unit. So a minimal score of 12 with no score one in any with no score or one in any individual category would be required for a patient to be fast tracked. Basically, it scores the level of consciousness, physical activity, hemodynamic stability, blood respiratory ability, post-operative pain assessment, and post-operative emetic symptoms. So it see here, post-operative emetic symptoms, post-operative pain assessment, respiratory stability, hemodynamic stability, physical activity, and the level of consciousness. 6 points. So in conclusion, patient procedure availability and quality of aftercare and anesthetic technique must be individually and collectively assessed to determine the acceptability for ambulatory surgery. A delicate balance must be maintained between the physical status of the patient and the proposed surgical procedure. Anesthesia for ambulatory surgery is a rapidly evolving specialty, and patients who were once believed to be unsuitable are now being considered for these procedures, and operations once believed unsuitable for outpatient are now being routinely performed. The appropriate anesthetic management for these patients before coming to the OR should be decided, and that is the key to success. The availability of short-acting anesthetics and longer acting analgesics and antiemetics enables better care and early discharge of the patient. So, preoperative evaluation, patient with presumptive diagnosis of OSA, not many comorbidities, with known OSA also. So, with known OSA, optimize comorbidities and should be able to use a CPAP at discharge, then only proceed with ambulatory surgery. If with the non-optimized comorbidities not suitable for ambulatory surgery, may benefit from diagnosis and treatment. If again with optimized comorbidities, post-operative pain can be managed by using opioid analgesics. So guys, that's about it on non-operative anesthesia. It's a very brief topic, and it's more like it's an easy topic which y'all can y'all can yourselves it's easy to answer if you know the basics of your drugs and what is required from the point of view of ambulatory anesthesia. And then what else would I want to say? So like they said here, preoperative, so any comorbid conditions like hypertension, arrhythmia, heart failure, cardiovascular disease, metabolic syndromes. So if all these are present, these are the associate comorbids with OSA, then they should be evaluated. And so all these conditions, whether OSA is present or not, have to be evaluated, and decisions have to be made based on this. So in patients with OSA, a lot of caution has to be extended, because these patients can develop prolonged respiratory and severe respiratory events. So guys, do use my code. That's it. Another 15 minutes I'll be finishing class, even on awareness during anesthesia. I'll take it up at 12:45. Till then, do use my code SASHE to avail your 10% discount, guys. You'll have a nice day and a good Sunday. I shall see you in 15 minutes. Do stay tuned.